So this session is entitled Perinatal Audit as a Tool for Improving Equity and Outcomes and access to perinatal pathology for stillbirth. And we are delighted to have an all-star panel here. I can't stress how important perinatal pathology. I can't stress how important perinatal pathology is, and this page and also JJ have really shown us in two studies showing the most important, by far, single contributor to finding a cause of stillbirth is placental pathology, and the second most important by far is autopsy. So we can't say how important it is. I think, in the United States, we're terrible at doing autopsies. Only about 20% of cases have autopsies. And just like everything else, there's considerable racial disparity in terms of and ethnic disparity and where you happen to live disparity and the other kind of disparity in terms of who gets offered an autopsy and who actually chooses to do it. So it's going to be terrific to have this panel here. We have Jess Comstock, who is our go-to perinatal pathologist who needs to be for all things clinical and research. And then we've got Jane Dahlstrom, who's a perinatal pathologist in Australia. She has too many accolades to list, other than to say that we're lucky to have her here. We've got Drucilla Roberts, who is the head of obstetric and perinatal pathology at Mass General Hospital and Research Institute, who also has too many accolades to list. We're really fortunate to have her here. And then we have Nathan Blue. Nathan is one of our junior faculty. So, yeah, terrific researcher in placental insufficiency, growth restriction, and risk stratification for stillbirth. And he's also been great in seeing patients with stillbirth. And we already know Debbie Haine, who is our rock star advocate, who's really fighting to overcome some of the barriers to obtaining autopsy in the United States. So thanks.
Thank you very much for the kind introduction. I too would like to acknowledge that we are meeting on traditional lands and pay my respects to elders past, present and emerging, and acknowledge the First Nations people in the room. So this is the outline of my talk, and what I'd like to just highlight is that this talk is available to anybody who would like it, because I provided a lot of links to resources in the talk. So in terms of our definition of stillbirth in Australia, yes, we have a baby who hasn't breathed the breath of life that is born at 20 weeks gestation or more and or weighs 400 grams or more, so slightly different to US. Our stillbirth rate, on average in Australia, 6 babies are still born every day, which is less than 1% of babies born. Our stillbirth rate is 2022 with 7.9 stillbirths per 1,000 births and 85% in the antepartum period. What's a little bit disappointing is over the last 20 years, we really haven't seen much change in our stillbirth rate, and most of our stillbirths are in the extreme premature group. As we've talked about already, in terms of our stillbirth rates, they're much higher in women who don't access or have limited access to antenatal care, who live in very remote areas, who are a First Nations group and are most disadvantaged. So what about perinatal pathology? So when we're talking about that term, we're talking about the perinatal autopsy or postmortem, which is the examination of the baby after death, and placental assessment. When we look at our national perinatal and mortality data collection, we know that nearly all families are approached about whether they would like to have any testing done. However, our autopsy rate for stillbirth is around 41%, and our placental assessment is around 82%. We know that there's a big geographical difference, being much lower in some states than others. In my own, it's around 66%. We also know that Indigenous women are much more likely to consent, much less likely to consent to autopsy than non-Indigenous women. And we also know that in our unexplained antepartum fetal death group, only 50% of families agree to an autopsy. So what are we trying to do to improve equity in perinatal pathology in our country? I think first and foremost, like we've heard today, is advocacy, particularly from our parent and community groups, but also a number of other groups. We had a recent Sentinel event, which was when Senator Christina Keneally was able to advocate to have a Senate inquiry into stillbirths in 2018. And this was a woman who'd had a stillbirth herself. This generated a report of some 187 pages, of which many people who are in the room here from Australia contributed to. But what was more important was that we were able to have a document produced, which is a national stillbirth action and implementation plan, an investment by the federal government of $52.4 million. We are now in the second year of annual reporting, and if you look at the areas of action 11 and 12, you'll see that there's KPIs about improving investigation and also tracking progress to reduce inequity. So a second area that we've been focusing on, much of this is a result of the federal government funding. They allocated $3 million to stillbirth education and awareness, and this is partnering with the federal and state governments and a number of educational institutions and tailoring the kinds of education to parents, the community, health professions and health organisations. Because we know from the literature it's very complex why families do not consent to some kind of perinatal investigation. So in terms of the funded educational resources for families, there's now a number of First Nations and multiple language documents that are available, so both written publications as well as visual resources, and I've put lots of links to those for anyone who's interested in learning more. Also importantly, through the work that Vicky's been doing in Stillbirth CRE, we've had an update in our nationally endorsed evidence-based guidelines for clinicians about stillbirth investigations, giving important information to clinicians about which tests to order, explaining the issues of options about autopsy, costs, and importantly, how to approach consent. We've also had an uptake in the improved course that many of you are going to be exposed to tomorrow. And it is really important because it provides uniform messaging about the value and barriers of performing perinatal pathology. My own college, the Pathology College, has been really engaged. They were allocated $750,000 by the federal government to increase public awareness around perinatal pathology services. They've done this through podcasts, publications, and getting lots of pathologists to be interviewed by various women's magazines, something I never thought I'd be doing. The third area has been about investment in perinatal pathology services. And again, our college has had a central role, as has a number of other organisations. The federal government allocated some $13 million to increase the number of perinatal pathologists as well as perinatal loss coordinators across the country. Money has been allocated to increase resident awareness of perinatal pathology as a subspecialty in varieties of ways that I've documented there, and also to increase education resources and opportunities for pathologists to subspecialise in perinatal pathology. Another really important bit of advocacy our college has been involved with is around making sure there are no costs to families, and this includes our non-permanent residents. So sometimes we have asylum seekers and other people who do not have a Medicare number, but everybody should not have to pay for autopsies. And so there's a lot of work going on there, and also increasing the rebate for a placental assessment. Some other things that we have that I think helps us deliver a high quality, well-resourced perinatal autopsy service is we have a single accreditation for our services. We also have single medical registration, so I can go anywhere in the country to do an autopsy. Equally, babies are allowed to cross borders if we need to do that because of a shortage of pathologists in one state or another. We also have national laws for consent, although unfortunately we still have some state-based modifications. Finally, the fourth area that we're trying to improve equity in perinatal pathology is through data collection, reviewing the stillbirths and research. So we have both territory and state-based multidisciplinary team reviewing all deaths. They're classified with one system, ZANS, and we also highlight contributing factors to highlight inequities if we so notice them. We have implemented a national perinatal mortality audit, and the government has provided quite a lot of funding for various research initiatives. So in summary, equity in perinatal pathology for stillbirths is complex and multifactorial. Education is key. Adequate funding for services is crucial, and more research is needed to assist with evidence-based decisions. Thank you.
Really hard to be asked to talk about autopsy and then being told I only have 10 minutes to talk about autopsy because autopsy is what I do. And I like to talk about it. And I talk about it to a lot of groups and I can go on ad nauseam. So I'm not teaching you about autopsy per se, kind of talking about the sideline of it and why is it sometimes so hard to get to an autopsy. And I'm talking about that from the perspective of the clinical staff side of things as opposed to the patient side of things, though both of those, of course, go together quite a bit, and the umbrella kind of covers everything. From my standpoint, I see two main problems. There's more, but these are the two that stand out to me. Is one, in Utah anyway, it's the clinician, it's the OB or the midwife or the ICU physician who is consenting that family for an autopsy to be performed on their baby. It's not the person performing the autopsy. Now that's different. There are some states where it's the pathologist that talks to the family about autopsy, but where we are in Utah, people who are consenting to the autopsy aren't performing the autopsy. So if the family has questions about anything, they don't always know because they're not the ones doing it. If you're going to go get heart surgery, you're talking to your heart surgeon, right? So it's a little different there. Also, patients are often talking to their nurses on the floor. You know, you're seeing your nurse multiple times a day when they're coming to talk to you. You might see your doctor once a day when you're actually in the hospital. Kind of depends on what's going on. So you're talking to your nurses. You have questions about that, and the nurses often don't. But they also don't have the information about autopsy. So parents are asking a lot of questions, and they may not be asking them to what might be the best people. Two of the most common misconceptions that I see here because of that is one, the cost. In Utah, I think pretty much everywhere in Utah, but most of Utah at least, autopsies are free to families. And I hear it constantly, weekly, that like, oh, I didn't get an autopsy because it would cost too much. Or a clinician talked about like, well, I didn't want to get an autopsy because it costs so much. It's like, no, it doesn't. It doesn't cost that family anything. I don't want to say absolutely zero because there's sometimes a question about genetic testing and if that's going to get charged to the family or not. Usually, if I'm doing it as part of my autopsy workup, it's not getting charged to the family. So there is no charge. So there's really not a reason to not get one. Occasionally, I'll have it's been quite a while since it's happened, but a family actually called me and they're like, well, we wanted an autopsy, but the doctor wouldn't order one. I'm like, what does that mean? Like, you don't sign the paper to get it. It doesn't need order, it doesn't need pay for, it doesn't need insurance, authorization or anything like that. So not always sure where some of that comes in. So I feel like I walk around with a banner sometimes saying autopsies are free, just because I want people to understand that that's what it is. Another misconception is about the actual incisions that are performed on the body during the autopsy. I some of the worst things I've heard said come from people who, of course, don't do them. They're like, oh, if you do an autopsy, you won't get a baby back to bury. I'm like, wait, whoa. Why would you ever say that? Because the one is just not true anywhere. Any incisions that we do are covered by clothing, by normal clothing, not even special clothing, just any normal clothing that you would put on that baby. Incisions are covered. You can do the head incision and still have an open casket ceremony. I know a lot of people who have stillbirths aren't getting as many open casket ceremonies as happen on life force, but it still happens. But you want to have a presentable child. We can do a head incision and remove the brain and still have that presentation be good. Now, if you're turning a big baby over and looking, sure, you'll see an incision, but it's hidden by a hat, it's hidden by a pillow, the baby's laying down. But the people who are consenting aren't the ones doing the incisions. They don't know how those go. So sometimes they can't answer those questions as well. But incisions are always well hidden. So how have we tried to adjust these problems? I am going all over the place. I'm talking with my MFM OB physicians, other OB-GYNs. I'm trying to get everywhere so that they know what autopsy is. I've given ground rounds lectures. I've sent out emails. I answer phone calls. A lot of people have my cell phone number and they're texting me like, hey, I've got this question about an autopsy that I just don't know. And I tell people that it's okay to reach out to me. I'm teaching them about the cost. I'm teaching them about the incisions. I'm giving them pictures of what it looks like. I'm inviting them to come to the autopsy suite and see an autopsy with me. That happens less on the OB surface, but more on the ICU surface, where they're able to see what I do and how we gently handle these babies for autopsy. I talk about the timing of the autopsy, like I can do that autopsy within a day or two and you can have your baby back pretty quickly. It may take 3 months to get the report back finally, but like the actual autopsy doesn't really take all that long. The kinds of information that can be obtained in the autopsy, sometimes people have questions and it's like, that's not something I can answer. And sometimes I can't even tell the cause of death, but I can rule out a lot of things, which I think helps a lot of folks that they've at least tried everything they can to look and can rule out a lot of things. I've done handouts for L&D nursing staff. That's actually gone over kind of plus minus. I think some people like it and some other nurses are like, this is not my job. I'm like, okay, well then when your patient asks you a question, make sure you tell them to talk to their doctor about it. Like if you don't want to give out information, don't give out any information. You don't want to give out misinformation. And so I'm still trying to kind of get myself in there with the nursing staff, but that's mostly, I think, now going to have to go through my MFM friends and my OB friends to try and get that done. But as much as I love to teach, my pathology residents about how to do autopsies, I really like just getting out to the clinicians to teach them as much as possible about autopsies so that they can talk intelligently to their patients about it. That's all I have to say. I'm not sure how intended.
Afternoon. It's quite an honor to sit with this set of amazing clinicians. And it was such a pleasure to be invited here from this force of nature there. And all you people were brave, and I respect you, and I really hope that you get something out of this that you can take with you. My talk is going to kind of be a review from the first two talks, but a little different angle. You've seen this map before, And the reason I bring it up is if you look at sub-Saharan Africa, it's trouble. And if you look at North America and Europe, it's not so bad, but we think of it as terrible, right? Baby stillbirth. But what I want to talk about is we haven't really talked about timing of stillbirth and how important that is to figure out what. So most or a large percentage of African stillbirths are intrapartum. So if you want to prevent the high rate of stillbirths, you have to improve access to medical care. And that would really decrease the stillbirth rate there. Most of the stillbirths, or a large percentage of them in Western countries, are anti whole different set of differential diagnoses. And if you want to prevent those there, you have to know what is causing them. And that's the only way you can figure out how to prevent them. So this is my one slide on disparities. I want to talk a little bit about racial inequality of workup of stillbirths, of the number of stillbirths, the number of doctors, and perinatal pathologists. But what I like to say, the second bullet point, there are huge racial disparities in stillbirth rates and maternal mortality in this country. But it's not race, it's racism. That's something we need to work very hard on in this country. And one thing that we really need a lot more diversity in the medical workforce. So this is obviously, we want to prevent stillbirths. And it's been said that at least 25% of stillbirths in this country are preventable. That's a lot. The preventable stillbirths, of them, almost all of them, or a great percentage of them, are due to placental insufficiency. So most of my work is placental pathology. So I'm kind of biased, but I'm going to talk a little bit about the placenta and how important it is. And here is another thing about the preventability of stillbirths by gestational age. Okay, so we heard about a few international studies, but there are very few of them. The investigation of causes is very limited. I'm on a big study in Massachusetts to classify stillbirths in the state. We're looking at all stillbirth records, and I'm looking at the data, and I'm trying to figure out what the most likely cause is. And it's shocking to me that almost all of them have almost no clinical data. The placenta wasn't examined, there was no autopsy, and there was no clinical diagnosis or differential diagnosis. So the obstetrician or obstetrics writer didn't even write down what they thought was. There is nothing. So this big study is going to just have a lot of empty data. And we've got to change that. And then the last point is one of my big drives, is that there are very, very few perinatal pathologists. And sometimes the placenta goes to pathology, and the pathologist has no clue about placental pathology. And that's our own fault. We don't teach it well to the residents. They get almost no exposure. So they get a placenta from a stillbirth, and they sign it out as placenta. Please,
Immature placenta.
Sometimes they say trimescular umbilical cord, but that's pretty much it. So I want families and obstetrics providers to know that if they don't have a perinatal pathologist on their staff, extend it to one of the few of us out there as a concept. We will do it pro bono if the patient doesn't have insurance. Most insurances pay for placental examination. And I think it should be required for stillbirths or neonatal deaths. Centers just should go. So here's the top 2 common causes of stillbirth in this country: placental, and so 24%, big amount, but that's why all the placenta should be looked at, and umbilical cord issues. The umbilical cord is completely least in the placentas, and it has not been studied as much as the meat of the placenta, the parenchyma. So we're just learning more and more about things in the umbilical cord that are associated with sudden death in utero. And there's things we can look for. And then there's all these other things that are less important, but the last bullet point, hoping to change, that up to 60% of especially term stillbirths remain unexplained after a complete examination. But as you heard, we can rule out a lot of things, and we can say that everything was developing normally. And that can be of some comfort to families, not the amount of comfort that I would like to give to families, but at least there was no anomalies that were unaccounted for that could go wrong. So the most important tools is the placenta, the placenta, the placenta. It has to be sent. And other things are microbiologic cultures and antibody tests on the mother. And if the baby is going to an autopsy, that should be done there too. The baby or fetal autopsy provides a lot of information as well. As I just said, not everything, but it can provide surprises that are clinically relevant as to cause of death, and it can rule out things that might recur. In Massachusetts, we always do a karyotype, and that's free with an autopsy, and we always do microbiologic cultures, which are also free, and the autopsy is also free. And as I said, the placenta is almost always covered by insurance. So this is my only picture. I have to show one. This is a nice normal placenta. And I think, as you can see, the umbilical cord has a twist in it. So one of the big things that's coming up is hyper twisted cords are very much associated with sudden death in utero. And it hasn't really been looked at for very long. So that's one of the things that I teach. Look at the number of coils in the cord and look for kinks. So placental pathology is the most likely cause of death. It can predict maternal or pediatric immediate and future outcome. Specific infections. There's some things in the placenta that are associated with demise that recur very commonly. If you can look at the placenta, it's going to recur next crisis. So that's a very important benefit of looking at the placenta. So how can we improve this field, perinatal pathology? As I said, I think all placentas for any pregnancy loss should be sent to pathology. It shouldn't be a question. It should be automatic. I think that all obstetric providers should be aware of the benefits of perinatal pathology. They should know that the placenta is important, and they should know that the autopsy is important. And as we just heard, they should know something about the autopsy so they can explain it, or they should call us. I'm happy to come see the family, and I have, to explain what we're going to do. And asked them if they want any restrictions. And we have just started a policy where we get post-mortem MRIs. You see a lot, almost as much as a dissection. So that's very helpful for some families who really don't want any decisions. And other restrictions can apply. You can say gross examination is just looking at the baby only. You can say obtaining tissue for karyotype and microbiology only. So we won't do the rest of it. And you can restrict however you want. And that is something that the obstetric provider should know and should tell the family. And this is a shameful thing about the racial inequalities in this country. The maternal mortality rate and the stillbirth rate is twice as high in people of color than in whites. And there are way more white doctors than people of color doctors. And to make a generalization, many people of color don't trust the medical system, partly for that reason. So they are reticent to do something that is recommended to them by a white doctor who they don't trust. So I think if a obstetric provider is available, who is a person of color, that's who should go and talk to the patient, even if they've never met that person before. Because all of the providers should be versed in talking about perinatal pathology to families. So it's just a shameful part of our country that that's true, and I feel hesitant to make this recommendation, but I think it really does. And that's my comment. I put my email address on there, so the providers here can email me anytime if you have a question about the case. I'm happy to look at it, pictures, my so thank you.
Falls to me without that little to open up this particular session. I do have a few questions that I wanted to ask. I know it's not
on the top mute.
On the top mute. Yeah, see? No. Someone's turned something on.
Hello. We're happy. All right. So I thought what I'd do is just ask two members of our panel who haven't spoken a question, and then open up to the audience. Does that sound like a plan? Hopefully you'll agree. So I guess my first question is a bit of a research one, so I thought I'd ask Nathan. So Nathan, what's one research question that you feel needs answering in the USA to provide a better understanding of inequity in perinatal pathology?
Thank you. So my name is Nathan Bloom. I'm a maternal fetal medicine doc here, and I'm a gigantic nerd. So this question for me. It's hard to choose one, so I'm gonna do two questions. Okay, two research questions. I think that even the easiest things to dispel are the misconceptions about autopsy, which is why it's so illuminating when Jess Comstock talks and is so helpful for our clinical staff. But even after you remove all the misconceptions, people will still have reservations or objections even to autopsy that are based on their own personal values and belief systems and experience and trust. And that is okay. The best that we can do is offer them all of the information, help them make a decision that suits their needs. And so I think that the research question, though, is we need to know what the reservations are that are specific to people's cultural backgrounds. So that we can, at the very least, dispel the misconceptions, address the reservations, help them get culturally appropriate care to make that decision. So that's the first thing. And then the second thing I think is much simpler and easier. And that is, I think that we could pretty easily put a dollar amount on how much it would cost to fund autopsies for everybody in our country. And that seems like, offering autopsy here in Utah, it's such a privilege to say, like, there will be no cost. And I think that is a really wonderful thing that we can do for people. But it is just adding insult to injury when someone is facing this scenario, and just to get the basic information to them requires potentially an unknown and large cost, which is just the way our healthcare system works. And so to me, that's sort of unconscionable. And I feel like we should be able to get everybody access to at least a basic workup, and putting a dollar amount on that would be a fairly simple way to know what our starting point is.
I think they're great questions. So I'm going to now ask Debbie, our stellar star here. So of what you have heard in this session, what is one message you would like to see action on in your community or institution?
I think everything that I've heard here today is needed to address our country's stillbirth crisis and improve outcomes for families. I think we definitely need to be training clinicians and nursing staff to be able to have these much needed conversations with grieving, shell-shocked families. And I also think that we need improved resources for families on how valuable the information is that they will get from these testings, regardless of whether it's, cause of why their baby has died, or, immediate health concerns of the birthing parent, or, management of subsequent pregnancies, and for many, actually, closure. But at the end of the day, what we need is to have more trained perinatal pathologist, because until we have, an increased number of trained professionals that are well equipped to perform these fetal autopsies and placental examinations, we're going to remain greatly limited. And so I think that is, a huge, huge, huge piece of this puzzle that I would love to see more of, and which is why we need to get the Stillbirth Health Improvement and Education for All Act passed this year, because it will fund, it would authorize funding for a perinatal pathology fellowship just for this reason. So thank you.
Okay, I can see a hand up at the back, so please say who you are, so I don't know everybody, and then go forth.
Hang on.
We love you.
You guys have so many here.
Hi, I'm one of our rare perinatal pathologists in the state of Utah. Recently recruited in faculty, but do you have ideas that you've learned through your work in another country how we can recruit? Because we are very short on pediatric pathologists, much less perinatal, which is a subspecialty within a subspecialty.
Yep, so I have lots of ideas. I go to the links on my talk and you'll see some of the initiatives that we introduced. I mean, one of the things is about having exposure. So we introduced a number of scholarships for our trainees who are doing general surgical pathology to spend time either in Australia or overseas. So one of them's going off to France and another one's going down to Victoria. It kind of depends on what is what they like, but there's a dollar value to it. And I think getting that really intense exposure in units that are excellent can be really transformative. And I know for myself that I didn't have the traditional pathway to become a perinatal pathologist. I did general surgical pathology, and it was actually because of the fact that a fetal medicine unit started in our city. I come from the capital of the country. I have to tell you, even So it didn't have a fetal medicine unit back in the 1990s. Anyway, and I realised there was a need, but I didn't have anybody to train me. So I then had the opportunity to go and do a fellowship actually in another city, in Sydney, and later on I had an opportunity to go to France. So I think that's one really important initiative, to have funded scholarships to give in these kind of exposures. Another way is to make it compulsory to actually get exposure to perinatal pathology as part of your training. So every surgical pathologist that comes through our department, and we have 6 or 7 a year, they actually end up spending 3 years or more getting exposure to autopsy pathology as part of the rotation system. And I think 2/3 of the junior perinatal pathologists in our country are now come from our department. So they're just 2 initiatives. I don't know how it would translate here, but got to try it, don't you? Yes. Please say who you are too, thanks.
Hi, my name is Barbara Reyes. I'm a doula. I work with an organization called Comunidad Materna in Utah. And we work a lot with the uninsured population here in Utah. And so my question is, when you say that all autopsies are free, does that even include the uninsured or undocumented families?
Yes, as long as your prenatal care was at, well, for Utah specifically, at University Hospital or within the Intermountain Healthcare System. Even the other, like St. Mark's Hospital System, they kind of contract with the university, so that covers the vast majority of Utah. Yes. So as long as you've been getting your care in one of those systems, it will work. A lot of times, even if you're getting care at, a clinic, an outside clinic, you still will often come to the hospital to deliver the child.
Right. Okay.
So if you've been out at Dr. Joe's OB clinic and you have a stillbirth and you come to LD Hospital in Salt Lake City to deliver, well, now you're in the care of LD Hospital, so now your autopsy is free.
Okay.
So.
And sorry, can I wanted to ask about a placental examination as well, because as we mentioned, most insurances cover that. How would an uninsured family be able to go about getting a placental examination?
I'm very fortunate to work where I work, and they would still examine the placenta at no cost.
Mm-hmm.
But that is not true over the whole state. The physicians, the pathologist fee can be slashed, and just the technical stuff can be charged, but it's still a rather significant charge for some families. But a lot can be gained by somebody in the labor room just looking at it. What color is it? What does the cord look like? Is there any big clots behind it? And that can be extremely helpful.
Can I take a picture and just email it to you?
Yeah.
Are you coming to Improve tomorrow?
Yeah.
This is core business. Can I just say that to you? This is core business. Core section of that workshop is exactly that. You will learn it all tomorrow. So yeah.
It's pretty cool. I just like reflecting on the theme of fragmentation. It's so interesting to see most of our international colleagues talking about national programs and most of our American colleagues talking about state level or institution level. And I sat in a few of these, and it's pathology where always you feel it the most because there are so few of you. And so I was wondering, this might be a question for you, Zan, but no pressure. But your center that you're launching, is this potentially like a place where the great experts that exist would be having, is it a resource hub where you could be doing things like sharing the talking points you just mentioned of how to explain it to parents, or also saying things like, here's sort of your menu of options. You don't have to go the whole way. the L&D brochure, and then maybe additionally like referrals for clinicians. You don't have the pathologist on staff here. Here's how you refer it out. Is that something? Well, I would just say that the people who are here in the room today, which is the experts up at the table and the experts down here. This is what the center is all about, is trying to bring people together and trying to, as I've been saying to our international colleagues, stop learning from you as much as we can and learn about all the stuff that's being done so mouthwateringly, fabulously in other places, and try to bring that learning here and also from other states. Our colleague in Drucilla and in Minnesota, all kinds. There are people from here from all over the country. And everybody's doing something great somewhere, and everybody has something to learn somewhere. So I would say that that's certainly an aspiration of our center. That's why we're
Are all of our talks available in PowerPoints?
yes. Obviously we'll ask the question. Yes, this is being recorded, and we're going to share the recordings and etc.
Can I just add one other thing? I do just want to point out, prior to COVID, we had one of the few trained perinatal pathologists in the country living in New Jersey with me, and she was a huge stillbirth champion. She actually was an OB that went into perinatal pathology because she just was sick and tired of delivering stillborn babies. And so we organized, one day I was at the bookstore and I was looking through a KISS series, which is the Keep It Simple Stupid. And I asked her, I'm like, do you think we could do grand rounds and you just kiss it? And she's like, what? I'm like, keep it simple, stupid. Just give these pathologists 3 to 5 things that they should be looking for. And we would be so lucky if we had the same 3 to 5 things that bit of information that everyone was collecting. So she was amazing and did grand rounds at many of the birthing facilities in our state. The PATH departments were clamoring for her to come. And so I just want to throw it out there that, the way I looked at it, it would be pay it forward. They would take this information wherever it is they went to go work or wherever they went to go teach. And at least, there were a few more people that had a little bit of a better understanding. Not as complete and thorough as all of your trainings, but just a thought that I also feel like that was tremendously helpful as well.
You have 1 minute. I forgot to say a very important thing. Ultrasound, perinatal ultrasound. They never look at the placenta or umbilical cord unless they're looking at where it's inserted. So I think that that's a huge thing that can be changed and can be very helpful because you can see a lot of things. You can see a small placenta, you can see infarcts, you can see hematomas. And that's something that families can also do when they're getting the ultrasound. Ask, how is the placenta look? I don't know why it's been ignored all this time, but I think it's just right for a helpful something.
Then
This is it. Sorry.
I can't do it. There is a international classification of perinatal pathology. It started in Amsterdam in 2014 in an ISA conference, and it has been fully worked out. And if every pathologist will report those items, which is noted there, you get a standardized report.
I'm all about Amsterdam. I love it. Yeah. Yeah.
So huge thanks for awesome.